last couple of days. I was not necessarily going to be a speaker this year. I think I've been able to do a couple different presentations over the last couple of years, but we had Joseph Anderson on the agenda, and unfortunately he became sick and he's been in the hospital for a few days. So just some prayers for Joseph, and hope he gets better soon. So you get another round of me this year. So I thought it would be good for us to talk about sleep navigators, the post-discharge opportunities that we have related to reducing readmissions for patients, and we'll spend a little time on that this morning. But first of all, let me say that my full-time job is I'm the Vice President of Sleep Business with Africa, and I'm part of the marketing and business development team with Africa, and we've got a booth here this year with Justin and Paige who do a great job. I'm also, my side hustle is that I'm part of a podcast called Sleep Tech Talk. So if you weren't a regular listener to the podcast before you came to this symposium this year, I hope that you will leave here and you'll listen to sleep apnea stories each week, and you'll listen to Sleep Tech Talk. Anybody listen to Sleep Tech Talk before? All right, I saw the first hand I saw, she went to a Sleep Tech Talk coffee month for being a listener. And I got 3 other opportunities for people in a coffee mug as well the rest of the time. If we're not connected on LinkedIn, I like to share lots of different things related to sleep and the sleep medicine industry. So feel free to scan the QR code. Let's get connected on LinkedIn, and we'll be able to communicate about things that might be interesting. So when it comes to the prevalence of obstructive sleep apnea, I don't think that I need to share a lot of information as it relates to just the overall prevalence, but really it's more the opportunity than it is anything, because the numbers and the statistics seem to always, no matter how many sleep studies we all do, it seems like the number never changes. It's been 80% for years, and I've actually seen some updated statistics from ResMed where they actually stated that 90% of patients who potentially have sleep apnea remain undiagnosed and untreated. But what is the economic burden that's placed on the economy based on undiagnosed sleep apnea? I think the thing that really stood out to me about this slide is all of the different parts of health and just life in general that all tie back to sleep. So when we talk about sleep, we always think about sleep as as a pillar of health, right? Well, isn't sleep really part of the foundation of health? Where it's not just sleep, diet, and exercise. It really is that it's diet, mindset, how we think about mental health, and all of the things that we've learned and talked about since COVID about mental health. But really thinking about sleep is the bedrock of all of those things: exercise and relationships. There it is. Sleep is the foundation of health. But yet, when it comes to sleep apnea, if we really truly believe that sleep is the foundation of health, then why don't we screen patients who we assume and think might have sleep apnea on a regular basis? Why isn't that part of just standard patient care? You go into the hospital today, and if you are, an 80-year-old fragile patient, there's a lot of times they'll get a fall risk bracelet, right? Just to make sure that we're taking care of that specific thing that may occur for that patient. So do you know that there is this little sleep apnea band here? It's not part of any healthcare system that I'm aware of as part of their regular identifications of patients who might be high risk for having some type of sleep issue. But it could be as simple as implement a stop bang and then identify the patient and then protect the patient. So let's talk about that. But there are some barriers and challenges when it comes to sleep in general. Okay. One of those things, I don't know if anybody saw this, but back last year, the U.S. Preventative Services Task Force came out with this. Should we be screening patients for obstructive sleep apnea? And it was a fairly lengthy, I would say, approach to trying to come up with this asymptomatic population of adults. Should we be regularly screening these patients for sleep apnea? And when it was all said and done, what they came up with is that there's insufficient evidence to recommend for or against screening for OSA in the general adult population. That was part of their overall recommendation. Can you believe it? I know that I can't, because some of the things that came out of that particular study was that adverse health outcomes associated with untreated sleep apnea include cardiovascular disease, cerebrovascular events, type 2 diabetes, cognitive impairment, decreased quality of life, and motor vehicle crashes. Severe OSA is associated with increased all-cause mortality. So it might kill you, but we're not sure whether you can screen for it. Right? So, ultimately it says, their final part of the recommendation said clinicians should use their clinical judgment regarding whether to screen and how to screen for OSA. What in the world? That's our government at work about. But wait, there's more. There's other challenges that we face when it comes to implementing screening for sleep apnea. And there was a survey that came out. This was sort of at the tail end of COVID, I believe, when this survey came out. And some of the results were pretty interesting. This was a survey that was sponsored. It was in Sleep Review magazine. It was sponsored by Itamar, I think, at the time. So yeah, it was November 2020. 89% of respondents believe they know what sleep apnea is. That's good news, right? If they have an idea of what sleep apnea is, they certainly would want to get it taken care of. 33% of respondents did not know that they could reduce the risk associated with cardiovascular disease, diabetes, and stroke by treating sleep apnea. But they were proven that sleep apnea is. 24% of respondents didn't know of the existence of home sleep testing. Well, they sure do now. We do lots and lots of home sleep tests. Increased prescriber required 50% of respondents would choose a home-based test solution as opposed to in-lab testing. Some of the top 3 concerns: cost, inconvenience, and COVID fear. I think the COVID fear probably is less than it was back then, of course, but still cost and inconvenience. And that was going into a sleep lab. 25% of respondents stated that they were either unaware that snoring could be a sign of a more serious health issue or did not believe it to be true. And then 23% suggested they would think twice before seeking medical help for sleep problems, with 28% stating outright they would not seek medical care at all. So they know what it is. They don't know that it can exacerbate certain medical conditions. And then ultimately, when it's all said and done, they're not going to do anything about it anyway. Again, why screen for sleep apnea? Still lots of opportunity, but when you start to look at these patients cost the system more. And I can tell you that based on some conversations I'm having with certain payers in the marketplace now, because they have become more interested in patient level adherence, meaning they don't want just home care companies to send over, hey, if you're Cigna, all of our patients associated with us are at this level of adherence. They want patient level data, meaning that they want an extract of that patient's information on a regular basis so they know whether they're using their CPAP or not. Because what they ultimately want to be able to find out is, number one, is that patient truly less expensive than a patient who is untreated or is non-adherent to their CPAP therapy? Interestingly enough, I think the other thing that they also want to eventually get to is they don't want to pay for a CPAP device any longer than they absolutely have to. So it means that we've got to stay focused on CPAP adherence, particularly on the home care side of things. But also just thinking about life expectancy. I mean, the fact that this is something that absolutely can kill you is something that should be part of why we have patients who come into the 4 walls of a hospital system, and we don't treat something that is easily identifiable, is easily diagnosed. Sometimes the treatment can be a little more complicated, but it's certainly something that we should be looking at. Sleep apnea diagnosis and treatment. So if you go online and start looking at chronic care disease management, you won't find sleep apnea anywhere. You'll find heart disease, cancer, chronic lung disease, stroke, all of these different health conditions, but you won't find sleep that's a part of these programs. In fact, I took these screenshots from companies that provide chronic care disease management to hospitals and healthcare systems, and sleep is not a part of the program, not at all. So sleep has got to become part of the discussion long term. Can I get an amen? Yes. What does AI have to say about this? So I wanted to, I went into Chat GPT and I thought, maybe it would think and think and think for a few minutes and not really give me any sort of answer. But, when it actually did populate, I was like, oh my God, this is pretty amazing. So results of proactive sleep apnea screening for healthcare systems. And I'm not going to read the whole thing. I'll just give you the 5 points. Early detection and treatment, reduced health complications, cost savings, enhanced patient satisfaction, and improved quality of life. Seems like a no-brainer to me. You go back to that U.S. Preventative Task Force, and they couldn't tell you whether to screen or not. But all of those things are sort of buzzwords in the healthcare industry as it relates to long-term patient care. And again, over here on this other side, benefits of proactive sleep apnea screening for health insurance providers, risk reduction, cost containment, long-term cost savings, enhanced customer loyalty, data-driven insights. I mean, go into Chat GPT and do this for yourself, because when I got these data points, I was like, well, there's my presentation. I don't have to spend much time talking about anything other than what Chat GPT just said. But again, it's, we've got the information, I think, that helps to drive the conversation. And I hope that I can walk you through, this process. Is there anybody who has a proactive sleep apnea screening in your hospital system today? One. Guess what? But I hope that even with don't tell me you don't drink coffee. Oh, you're drinking. Well, you're drinking tea. There you go. It'll be a pencil holder at the edge of your desk. All right. So I hope that even some of the things that I talk about today, even for her program, may be something that is and I found this to be true. I spoke at the Philadelphia Sleep Conference earlier this year and talked about this program. And even some of the people who were in the audience who had sleep apnea screening programs in the hospital, there was a few things where they were going, well, we don't do that. So I hope that there's a few things that will be of interest to you in this. But how do you get started? It's sort of like eating an elephant. How do you do it? One bite at a time. So the very first thing is you have to start with screening. And sometimes when I talk about this program, it gets a little complicated in the discussion. Is my elephant a little, is it bothering you? Okay. We'll just wait till the next slide because there's a bite out of sometimes the conversation can get a little diluted because there are some components to this that ultimately can reduce hospital readmissions. But hear me saying that the very first thing and the most important part of all of this is that you've got to start the screening process in the first place. And I know it sounds simple. Well, we'll just have a stop bank survey or whatever the case may be. And trust me, if it were easy, then there would have been more than one hand that was raised when I asked the question, who has a sleep apnea screening program, right? One of the things I will tell you is that many of the hospital EMR systems, particularly Epic, for sure, has a stop bank survey or a sleep apnea survey that's built into the system. But there's a couple of things about that particular screening is that typically it is not mandatory. And when it's not mandatory, it doesn't happen, right? So the very first thing is that you have to identify, is there already the sleep apnea screening program that's built into the system? Can we activate it, number one, or is it active? And number two, it has to be mandatory for all patients who are admitted to the hospital. But let's make it even a little bit more simpler. If you're trying to justify the need to implement this program, if you have to start with a paper copy of a stop bank survey and a very small patient population, so maybe you're only doing it for, through the respiratory department. As a respiratory therapist engages with a patient, they go through the stop bank survey with the patient, and they collect the results. Okay, so at least figure out a way to start the program and start the screening, because what you want to be able to report back to administration is what is the potential prevalence and opportunity that exists within the patient population that's inside the four walls of the hospital today, right? So you just want to justify the potential opportunity that might exist. I would also, limit the implementation of that initial screening to just a couple of weeks. You don't have to, because I think that the idea, if you try to implement it on such a large scale to start with, I think it becomes so such a large activity that sometimes the administration won't buy into it because it's going to take a lot of resources, right? So just do it for a small period of time with a very specific patient population, and if you just pick either patients who are being seen by respiratory or who are part of the cardiovascular program, I think you're going to find that the prevalence is very high, and you'll have some pretty impressive numbers to be able to report back to your hospitals. One of the things I can tell you for sure, though, is that any program that I personally have ever been involved in, 25% of the entire patient population in a hospital will be undiagnosed and untreated for sleep apnea, and they will screen positive on stop apnea. 25%. So if you're in a 1,000-bed hospital, that's a lot of people laying in the hospital beds that are untreated and undiagnosed and untreated. And the other thing too is you got to get a cheerleader. Whether it's your medical director, whether it's a hospital administrator, you've got to have somebody else who's part of your the healthcare system who's going to help advocate to the right people and get to the decision makers who ultimately will find this to be the right program. Sometimes it might even be somebody who's in the risk management department, because isn't this a risk issue for a hospital to have a patient who has undiagnosed sleep apnea or laying in a hospital each day and oxygen desaturations, long pauses in the breathing? Seems like that might be an area of interest. But once you've made your case for implementing there you go, Candace. There's the elephant with the bio. One piece at a time. Once you've made your case for implementing a screening program, how can this be done permanently? Again, I talked about the EMR system. Multiple EMR systems that I'm aware of. There's even one, it may be Cerner, but it could certainly be a different one. It's been a long time since I've dealt with that particular one, but it had a different type of sleep apnea screening. It wasn't stop bang, but I think it asked 3 or 4 questions, but it certainly would have identified the right patient group you'd be looking for. Okay. Once these patients are identified, then sort of what's the next step? Is it going to be well, we had Massey Harrington who came a couple of years ago, maybe it was even last year, and talked about his sleep navigator program. They screen all the patients at WellStar for sleep apnea. But because the stop bang survey produces so many patients, they only see the patients who score a 5 or more. Imagine that. They have to, they don't go see the patients who score 4 or more on stop bang. They just provide them with information so that they can pursue dealing with sleep issues after their discharge. So you have to sort of think about from a capacity standpoint, what's going to be the threshold that would implement a sleep navigator visit or, potentially a physician consults. And I'm telling you, every program is different. You have to customize the program based on sort of the operations of the hospital. Meaning, is there the ability to utilize some day staff in the sleep lab to do sleep navigator duties? Could it become part of the discharge planners activities that they are the ones who are doing education for the patients? What is sort of the right pathway at your particular facility to be able to move a patient from undiagnosed to being diagnosed and then to ultimately on some type of therapy? But again, for WellStar, which is probably the largest healthcare system I'm aware of that does proactive sleep apnea screening on their patients, they chose 5 or more on stop bang survey as their threshold. Here's the other problem. Does the sleep lab have the capacity to even handle the number of patients that might produce from a sleep apnea screening program? Is anybody backlogged? All right. I saw somebody up here. That's good. Why is your sleep lab backlogged? No tests. All right. Well, here's just a sidebar. If your sleep lab is backlogged, start triaging your patients as they're referred to the sleep center. Are there sort of uncomplicated patients who could be moved to home sleep apnea testing so that you can make room for patients who are of higher priority, who have comorbid conditions, who really need to be in the sleep lab? what would be the harm in making sure that a patient can get diagnosed timely, even if it's with a home sleep apnea test? Right? Because implementing this program is going to exacerbate a backlog at a hospital. And what I don't want you to have happen is that you go start having a conversation about implementing a sleep apnea screening program, and you have no capacity to handle any additional volume in the sleep lab itself. That's a problem. You also don't want to do sleep testing while the patient's in the hospital because you're not going to get paid for it. And ultimately, that's part of this conversation too, is that you have to look at, what's the financial opportunity for the hospital? Can you drive additional revenue through these new tests that are going to come by identifying patients who are part of the healthcare system in the first place? So that sort of the next step out of all of this is OSA positive protocol implemented for positive screens. I cannot take credit for this. I found an article from years ago, a couple years back, about a hospital system. It's in the Pacific Northwest, I think, that it's a 36-bed hospital. They don't have a sleep physician who is even remote. The physician is licensed in the state, but he is not on site to see patients. This hospital system implemented a proactive sleep apnea screening program. They have a sleep lab, a busy sleep lab, and they also have a nurse practitioner now who's dedicated to doing sleep clinic on site, who partners with a physician who reads all of the sleep studies there. So, and we'll talk about part of their sleep apnea screening program is that they developed a protocol to protect patients while they're in the hospital. And I bet that your hospital doesn't do this even if you screen for sleep apnea, because as soon as I saw it, I was like, this makes complete sense. We'll talk about that. So the Sleep Navigator program, what does it look like? But here's sort of the primary components: screen and protect, educate and coordinate, diagnose and treat, and then monitor and report. Monitor and report is where we reduce readmissions. So we'll get there. So the stop bang survey, and here's the piece that I was mentioning earlier. But let me not skip over the wristband piece. Once we identify these patients, they screen positive, then let's put a wristband on. Remember, I went all the way back and I was talking about the fall risk at the very beginning. Why would we want to let every person who comes in contact with that patient know and understand that that this patient might have sleep apnea that's undiagnosed and untreated? Just like we did for the 80-year-old lady who may fall. Because ultimately, let's say that patient has they're admitted for some issue, and at some point they need to go to surgery. So now you're taking a patient who has susceptible airway, you're going to go and put the patient under a general anesthesia. They're going to go to a recovery room, and there could be some complications that occur because they have sleep apnea in the recovery room. And anesthesia would certainly treat that patient very differently. So we've identified the patient. We, by virtue of screening the patient, we put an armband on the patient. We flag the chart, obviously, and then the next piece, and I think this is a real difference maker, is that you potentially develop this OSA protocol, meaning that how can we protect these patients without necessarily putting them on CPAP while they're in the hospital? We flag the patient, we've got an armband on, let's elevate the head of the bed. Let's educate the patient to avoid supine position, right? I mean, these things are very easily attained. And for this hospital, it was amazing. I'll show you some of the stats. How many patients had to go into the OSA protocol that they screened? Some of the other things too, considering pain management. Maybe the physicians who are treating that patient may want to use a different approach to pain management for those patients because they have a vulnerable airway. Right. Doing some things to make sure you're maintaining the oxygen saturation for these patients. Maybe it's continuous monitoring of end-tidal CO2, and then even potentially putting the patient based on if you have a patient that you do a stop bang survey on, and they answer 9 of 10, you probably should put that patient on a CPAP device while they're in the hospital just to protect them while they're within the four walls of the facility. The Sleep Navigator, this is the educate and coordinate part. The patient's done their sleep. The sleep assessment comes by the navigator going in and doing some additional work, the additional workup of the patient from a history and physical standpoint, and information to be able to review with the physician that's assigned to that patient. So let's say that there's a hospitalist who's the attending for that patient. The sleep navigator would absolutely be the person who can go in and get the information on the patient, report back to the hospitalist, who then writes the post-discharge orders for that patient, which include getting a sleep test once they get discharged from the hospital. And all of that needs to be coordinated timely to make sure that the patient is getting an expedited sleep test, because you don't want to identify this patient, protect this patient, then send them home, and they can't get into the sleep lab for 6 weeks, right? So there has to be a lot of work that goes into sort of coordinating this patient's care from initial surveying all the way to getting tested. But once the patient has their sleep test, you're going to the results are going to be reviewed with the patient, and then the CPAP plan of care would be part of what needs to get coordinated and negotiated and educated for the patient. And then, once that CPAP gets set up, now you've got a payer-provided CPAP device, and that's where the long-term monitoring piece can come into play. So we'll talk a little bit. Once a patient is on a CPAP device, here are some of the other things. Like, again, this is where I talked about. This is where we can start to really focus in on reducing hospital readmissions. There is, a patient typically is on service with any DME company. They're going to be a part of an adherence monitoring program. Hopefully those DMEs have sleep coaches who are coaching those patients. And then also part of a resupply program to make sure that they're getting and engaged in resupplies. If a patient ever tells you that the home care company shipped me all of these supplies and I got stuff stacked up in my closet, they're not changing their supplies often enough. It's not necessarily because I promise you that the payers don't. They only pay for supplies on a very specific, timing schedule, and it's not such that you would have stacks and stacks of things in your closet. It's just that they need to replace their supplies more often. And then ultimately, what we want to do with these patients, once we get them diagnosed, we get them treated, we have them on a device. We want to make sure that we're tracking and reporting the outcomes, because ultimately the long-term outcomes are what is going to drive the success of programs, sort of on a national level. Now, the sleep navigator's role specifically. Is anybody a sleep navigator who does this kind of work in your hospital? Nobody. If I was a sleep tech working nights, this might be the job that I would want. Because I think it'd be a lot of fun to be able to go in and work with a patient. I mean, you sort of have to do coaching and motivation and that sort of thing with patients anyway when they come in for a night study. So, why not, work during the daytime, for one, but then secondly, you know that you are making a difference in the overall healthcare system and in that patient's life. So part of this sleep navigator's role, and, it is a catch-22 for me, because, I want sleep techs to occupy these positions. But I don't know if anybody has heard this statistic, but last year, the VRPT of the sleep techs who were set to recertify their RPSGT certification last year, it's either 20% or 30% of those techs did not renew their registry. How about that? So I don't know what the total number was for last year, but 20 to 30% of whatever that number was means that a lot of people are not sleep medicine. I mean, even one of our speakers yesterday said that he didn't renew, that he let his registry lapse. He still works in the field, but he's not a registered sleep tech any longer. So, that sleep navigator's role is, and I always try to focus on this one particular point, because I think it's important. And I think that this is where, as a sleep tech, you have to be well-rounded in your knowledge and education about other healthcare, other health issues. So that way, when you are providing education to the patient related to sleep apnea, it is condition-specific patient education. So you tie whatever the issue is that they're in the hospital for, whether, let's say that it's a cardiovascular issue, then go in and talk to that patient about issues related to sleep apnea and the heart. So that way they sort of understand what the reason is they need to get their sleep apnea taken care of. Once the patients are discharged from the hospital, and this is interesting. So Massey Arrington with Wellstar in Atlanta has amazing program. He has some of the best sleep navigators on the planet. In fact, one of the episodes of our podcast, it was the largest podcast episode where we had the most people, but we had 3 of the sleep navigators on the show. They are amazing people. They do great work. They don't monitor their patients' sleep patterns once they are discharged from the hospital and actually get tested and are on CPAP therapy. But what if they did? What if they did? We'll talk about what that looks like in just a second. But because I think that's where you conclude your program, is monitoring that patient once they get started on CPAP therapy, so that once they pass the 30-day threshold of potential readmission penalties, now you've identified the patient, you've diagnosed the patient, you've treated the patient, and you are monitoring that patient for the 30-day post-discharge period, so that now you can prove, because we did this for this patient, we helped that patient not go back into the hospital, because the goal would be to coordinate that patient into a physician office visit versus coming back into the hospital. Is this a lot? Remember, we started with sleep apnea screening. Don't forget, that's the most important part of this whole program. Now, I know that Drew and Teresa just talked about remote patient monitoring. Did you know that there are these different codes: chronic care management, remote patient monitoring? So there are codes that can be billed for these different services, and all of the platforms that are out there, ResMed, React Health, Philips. Do you know that a BiPAP device doesn't just give us AHI and usage data? It also gives us minute ventilation, tidal volume, and respiratory rate. Are those important to help a patient who's post-discharge, who exacerbated, went into the hospital for COPD? Sometimes physicians order for BiPAPs for patients post-discharge, and they don't qualify for it. Well, guess what? There is a pathway to get a patient on the BiPAP device. Send them through the sleep lab. They're probably going to be non-tolerant to CPAP. They get a BiPAP device. And that's the unit that they need to be on. Even an increase, there's some clinical studies that show just a small increase in respiratory rate at home for a patient who's a COPD patient is very likely that that patient's going to remit. And we know exactly what the respiratory rate is every night because it transmits into one of these platforms. So you think about the Sleep Navigator as this, I've got a picture of a lifeguard here. It really is a lifeguard because you're protecting that patient. The very first patient that I was ever part of the program where we were working to try to reduce readmissions, we were able to get the patient diagnosed. We got a patient on a CPAP device. We got her into like day 25, I think it was, in that 30-day window where if she readmitted, it would have been part of the readmission penalty for that hospital the next year. And I think she readmitted on day 25, but it had nothing to do with her respiratory. Just showing you it's hard. I mean, every patient's going to be complicated, and it is a difficult program, but I think ultimately it's worth it because number one, we've protected patients. We've increased the volume in the sleep lab. If your sleep lab, if your beds are going to still continue to be full, if you have significantly ramped up the number of home sleep apnea tests that you're doing, I think that there's good news there. You've increased the revenue in the sleep lab, and everybody's still working. There's no issue with techs being concerned about the long-term, impact on their job. So some of the things to also consider. We've kind of covered these topics here, but this is the sort of the tail end of this whole thing. Is that on the home care side? Does your hospital provide CPAP therapy? Do you have trusted partners that you can work with in the market who are going to be able to segment this patient population so that you can report on the outcomes of those patients, so that we know what the real success story looks like for these patients in the long term. And I've got a little variation of this program I'll show you in just a minute that I think helps to even bridge the gap, because there is a period of time where a patient gets discharged and actually is able to get on a payer-provided CPAP unit. And obviously, in some cases today, it takes 7 to 10 days to get authorization for a CPAP when you start the process. And that has nothing to do with the unique company. It's all about the payers and how long it takes the payers to give you the authorization. So the home care company, I think, is a big component in all of this. And then, are they a part of, and how do you track the outcomes? What does that look like? Here's that hospital that I was talking about a little bit earlier. Again, no sleep doctor, but they have a sleep lab, a successful sleep lab. They have implemented an extremely successful sleep apnea screening program, and ultimately they are working to reduce readmissions at their hospital. But yeah, I think this is a couple things that were interesting here is they developed this task force, and it was so successful when it was all said and done. Let's see where it's at here. Oh, they were able to justify adding sleep services, and they expanded screening to their primary care clinics. Holy cow. Not only was it so successful in the number of the prevalence of patients who were identified and screened in the hospital, they rolled the program into the primary care clinics. Can you imagine that the hospital systems that you work with, if all of the patients in the primary care clinics were screened? Could you handle the volume? No way. And then I think some of the other interesting statistics down here, 3,985 surgical patients were screened. Let me tell you this, though. Do not go back to your hospitals and start trying to screen patients pre-op. It is the worst place on the planet to implement a sleep apnea screening program. Is that right? Because the patients never follow up. Unfortunately, you do a lot of work on the front end. You get excited about the number of patients that you've identified, and then they go get their surgery, and you don't see them again. But out of the patients, 95% had a preoperative assessment completion rate, so they were capturing almost every single patient. Of those patients, 74% went on to need the OSA protocol. This after the fact. So I told you they had identified these patients and using this protocol. Everyone, I promise you, every person who works in that healthcare system understands what sleep apnea is, the impact that it has on a patient's overall health, and then ultimately they use this to be able to protect the patient at least while they're in the four walls of the hospital. That's good stuff, right? So a few years back, we actually had Christina Weaver come and speak here at the Carolina Sleep Society Conference. She developed one of the first sleep navigator programs in the country and was able to put out some information. You can see her clinical study down here. But 30% reduction in readmissions for newly identified sleep apnea patients over the last 4 years. One of the most impressive things I think about her program is the fact that they don't use one DME. They use lots of different DME companies, and they track all of the patients. So they just put a ton of effort into that post-discharge activity to ensure that those patients were monitored carefully and they didn't come back into the hospital. All right, so another variation of this program. Again, we had one more step before, but this is a little bit more of a modified version of this, but screen and protect, diagnose and treat, monitor and report. So what we're missing is educate and coordinate, right? And the reason for that is because I had the opportunity probably a year ago to meet with the hospital system, and they said we have 0 resources to hire a sleep navigator. Okay. So it sort of made me go back to, how in the world do I put a program, together? And when it was all said and done, they loved the idea of this. And in fact, one of the hospital systems I work with today, we have a program in place where there is a loaner CPAP device that goes home with the patient, some patients who are not able to pay for a CPAP device themselves. But essentially, it's a lot is the same. Stop bang survey on the front end. You still put a wristband on the patient. There is a sleep discharge plan. So this becomes a little bit more of a discharge planning activity than it is this education and coordination. It's just part of standing orders for patients to identify on the front end of the stop bang that they are going to have a sleep study as part of their post-discharge care. Okay. So it's going to take a lot of planning between the discharge planning department, the sleep lab, and the patient to make sure that happens in a timely manner. But in the interim, that patient is going home and walking out of the hospital with a CPAP device. How powerful is that when a patient didn't know that maybe they knew they had sleep apnea, they didn't want to do anything about it. They go into the hospital and they're walking out the door with a breathing machine under their arm. I think that sends a message to the patient this might be important, right? But the good news is that, that at least gives us a window of time to be able to start to work through the plan of care and the diagnosis and the treatment for that patient from a long-term perspective. Because, essentially, we still want all the other components to take place. Expedited sleep testing. We want to make sure that the sleep plan is, and that there is a physician who's assigned to that patient who understands how to care for a patient who's on CPAP therapy. And then, ultimately, that patient needs to get on a payer-provided device. It takes a lot to put this upfront work together, and even working through different legal things that need to take place to be able to get that longer CPAP put on that patient. It's something that the hospital, in the particular instance that I'm working with personally, the hospital pays for that device for 90 days for that patient post discharge. They don't get reimbursed a penny for it. It's just the right thing to do for the patient. And then, obviously, and ultimately, what we want to happen is for that patient to get their payer-provided PAP device, whether it's CPAP or BiPAP. And then all the pieces here at the end are exactly the same. All of the support, sleep coaching that needs to be in place to help a patient be adherent to their CPAP therapy needs to be in place. We need to be monitoring that patient. Even that has to be different. If you're a sleep lab and all you're doing is diagnostic sleep tests, and you don't think about a long-term impact on a patient, and you're not a part of that patient's long-term care, then I encourage you to consider, can you even log in and see your patients who have been diagnosed in your sleep lab to know what their CPAP adherence is? Because here's the other opportunity, out completely off topic for this, but if you're not currently monitoring CPAP adherence, then wouldn't it make sense to maybe get involved in that so that patients who are non-adherent to CPAP therapy might be introduced to Inspire? So now, as a sleep lab, you've not only created revenue from a sleep testing perspective, you also helped patients get to a therapy that maybe they can tolerate with Inspire, but those surgeries have to happen because of the stuff that happens first in the sleep lab. So, as part of your program, your sleep programs, I'm just encouraging you to become a part of the patient's long-term treatment. Even a patient who's on CPAP therapy, every 5 years, Medicare will pay for a new CPAP machine. Why not contact that patient after 5 years to say, hey, we want to make sure you're coming back in to see the physician. From an evaluation standpoint, there may be some additional sleep testing for those patients that needs to be done, but just become part of the follow-up care for the patient. All right, questions and answers. I hope I have some answers. Any questions? Oh, and my last topic.
So the Sleep Navigator and the reimbursement, I'm getting huge pushback from my health system that we are affiliated with. They refuse to pay us, allow us to bill those codes. So what do you do?
So all of the remote patient monitoring and chronic care management codes that I posted up here earlier, it has to be billed through the physician practice. Okay, it has to be billed through the physician practice. The DME can't bill for it. The hospital system, most hospital systems don't bill for remote patient monitoring. That is a physician office billing code. That's where it needs to happen. The one thing I'll tell you about the Sleep Navigator who's going to the bedside and providing education, there's no reimbursement for that either. So you have to tie the test that get done after discharge to that physician in order to justify the role. And I met with one hospital administrator. I talked to him about this, type of program. And his very first question, I was thinking, yes, he gets it. He said, how many sleep studies do we need to do to pay for that physician? That's a great question. Because every study after that just becomes revenue. Okay. You go through the physician practice hours.
Yes, but just because we're affiliated with the hospital will not let us.
So that's a hospital decision. Yep. And I will tell you, sometimes hospital policy doesn't necessarily make sense, even if it's allow for you to bill through the physician practice. There's a company, and I'm not pitching this company, but there's a company called HealthSnap today that they go into hospital systems. They use AI to be able to find patients in the hospital's EMR system who would benefit from remote patient monitoring and chronic care management. Those patients are then put into a program. It's a voluntary program. They don't have to participate in it. But once they're put into this program, there's a nurse who's assigned to that patient who will do everything that they need to do to make sure that they meet the billing criteria for remote patient monitoring or chronic care management from a billing perspective. So now you've assigned a patient to these high risk patient population, and you've created a new revenue stream for the hospital that they didn't necessarily have to build the program themselves. They were able to outsource it to this company. Prisma Health in Greenville, South Carolina, I guess they're all over South Carolina, works with health staff, and they implement that program. And I know that they have reduced their readmissions because they have closer, tighter management and monitoring of these super high risk patient groups. Yeah.
As far as I'm from used to be hospital based lab.
Yeah.
So when you already have a 6 month back, okay, then you're doing potency testing on patients that readily go on. We see a challenge sleep labs who are no longer based like you're in a hospital, we call the code, we gotta call 911 now. You know, and that seems to be with sick patients labs. I need to really have to get some steps in place for that.
I agree. I think all of this is, and that's why I said this. It seems like, and I'm not trying to make this oversimplified because it is a complicated. It can be a complicated issue because you're 100% correct. Patients are going to get more acute as you drive a program like this, because ultimately they're coming out of the hospital. They have multiple comorbids, but the other part of it is that we have to make sure that there's not a patient who is maybe a little overweight, has high blood pressure, and snores, is there in the sleep lab taking up the bed. But it also means for us as sleep techs, we need to know what the heck we're doing and how to take care of these patients who are sick. So, I think years ago I did a presentation for on a sleep study, and I talked about this, that there were things that were getting posted on Facebook that scared me to death, where people were posting arrhythmias that were occurring in their sleep study that night, and they had absolutely no idea what it was. So they're posted on Facebook to find out what the arrhythmia was. It's like you have to understand how to read an EKG. That this is basic healthcare, and really gives the responsibility to sleep tech to be confident enough to care for a patient who has those comorbid problems. It's also going to mean more complicated types of titrations where you're doing ASV and O2, AVAPs, and all of those things. But I think sleep techs do a great job, and I think we can take care of those patients first too. But I think we have to prioritize the patients who are not necessarily as acute and get them diagnosed through the home sleep testing pathway. And there should not be a backlog. I mean, I guess I know there's a lot of different reasons, why a hospital system may not necessarily sort of open up. Why would you have sort of unlimited capacity of being able to do home sleep testing as part of your program? Because you only have 10 home testing devices. Well, figure out a way to get some more devices. You know what I mean? There's got to be a better way. I was working with a hospital system not too long ago that they have I think it's a 12-week backlog of home sleep tests. Just home sleep tests. Their sleep lab booked out further. I think they're booking in 2024 right now for in-labs. So we have got to figure out a way to get more resources to that. Get more devices, in there from a home testing perspective. Pete Bruce back there, he'll sell you as many home sleep testing devices as you want to buy. He said, yeah, he's raising his hand. So see Pete if you need some home testing equipment. But yeah, it is the problem. I think you have to sort of think about everything collectively as you sort of go into these programs. But remember, go all the way back to the very beginning. You have to start with the proactive sleep apnea screening in the first place. Because if we don't do that, then nothing really, we don't need any of the rest of this in place. We've got to start with the screening piece. And ultimately, if you just get the screening started, you get the OSA protocol in place, then you're well on your way to getting a successful program going at your hospital. And yes, you will at some point need a lot more sleep tests. So you might want to start a sleep education program.
I would say you were correct, 30% reduction in RPSGTs. More people left and more people passed the test and became techs. There is.
He's on the board, by the way, as a DRPT. Right?
No, I'm with COA and
Okay.
there may be a task force with
Oh.
everyone together.
Well, there you go.
There is a survey that's going to be coming out asking what do you think would make it better. So everybody get it checked. There is a box for pay benefits.
So you just said 30% didn't renew, and more people left the field than entered the field.
BRPT currently has a 40% pass rate, 46% pass rate. But they claim that's because first and multiple attempts, they say 65% pass rate people take it the first time,
Yeah.
and then a 70% fail rate for anyone who takes it multiple times.
I don't have anything to say about that. That is what it is. Did everybody hear all those statistics on this side of the room over here? Okay. I don't know if you want to hear it again. You know, it just screams that there's opportunity though, right? And we have still so much to do. So with all this AI and all the technology advancements, there's still tons of work for us.
I guess my question would be, to you. I'm sorry, I didn't catch your name.
Right.
Now, you said he's with the BRT?
No,
Okay, I just feel like you're making that test so hard because at my facility, all right, so there's no schooling around, so we took on the project of educating, like taking them brains, right? And building them up so they can take the boards, and we have techs that have taken the boards multiple times and not passed. You know, I just feel like they're making it so difficult now, for them to pass the board. I mean, stuff that they'll probably never even see, you know, in the sleep world, you know. So it's like, how do we get to a point? I know this is tough, I know what you're talking about, right? But I got my glass, I got my mug, you gave me a mug. You gave me a mug, I got a mug, right? So it's like, how do we address that to make it a little bit, I'm not saying dumb it down, you know what I mean? But make it so they can pass it, so they can, I feel like that's a part of why we don't have so many techs in the field now, is because they can't pass the boards. And so you have techs that have been in the sleep world for years, and now they're trying to get registered and they can't pass, you know? So how do we help that situation?
Adderall, yes. You know, so maybe it's that we don't change the test. Maybe we figure out a way to provide more education and easier access to education on the front end. And I know you definitely agree with that, right?
Yes.
Okay.
Let you know what your test gave you some kind of handle with it.
Okay, so he was saying that we need to make sure that people who fail the test understand what parts of the test they missed in the first place, so that the next time you go back, you have a better understanding of what you need to cover.
I have to agree with you. It's the education. My respiratory board is easier than the sleep board.
Wow. Sometimes it might even be the way that the questions are asked. I remember when I took the respiratory exam, which was probably before a lot of you were actually in sleep medicine, but you know, even the way that the questions are laid out, where you know, might ask, what's the definition of a K complex? You know, if the answer should be negative sharp wave followed by positive, and the next response would be positive sharp wave followed by negative. So it's more to trick you than it is to actually make sure you know the correct answer.
So on that, I took part in the standard setting with the BRPT in part of. And I didn't realize it until I went to that, but a lot goes into the exam questions. So they collaborate with Pearson View and sit down in a room with subject matter experts and go through the questions, how many questions are in each category, and then they've recently done some changes on them, whether it's easier or not, I don't know. As far as that studying, a lot of times I think we take, just say, you're reading out 10 different books, but really we need to focus on a couple different books, especially like the scoring manual and things like that, but, I would just say reach out to your team with that, but there is a lot that goes into setting up exam questions, which I didn't realize